Well, here we are. The anticipation is over, so let's go straight to the cath lab in Rotterdam from Erasmus Medical Center, where Nicolas and his team are ready to start. Nicolas, tell us about your case.
All right, Kendra, welcome, and welcome everybody else to our Alain Cribier room. I'm here together with Rutger Jan Nuis and our great team of nurses and technicians, and also research fellows. So we have Marek as fellow, we have Quinten, we have Marlejo, we have Stefan, and we have Lynn in the room. So we should be well prepped for this case. Ellie, what kind of procedure do we have?
Absolutely. So welcome to this valve-in-valve case in a complex peripheral anatomy. So this is a 79-year-old female patient presenting with dyspnea, and her medical history reports coronary artery disease in 2015 that was treated with a stent. And then in 2016, she underwent surgical valve replacement and received a peri-mount 23mm bioprosthesis. In addition, she had a permanent pacemaker implantation 4 years ago. Next slide. So the workup revealed by echo a preserved LV function and a severe stenosis of the peri-mount bioprosthesis, so a severe degeneration. Next slide. So 6 weeks ago, she underwent a coronary angiogram and was immediately treated for her lesions that we found at that time. So in the upper left corner, we see the LAD, and at the septal takeoff, there was a lesion that was treated. In the right upper quadrant, we see a good patent LAD after stenting. And more or less the same on the left lower panel, we see a lesion in the CX that was treated in the middle lower panel. So she was completely revascularized. Next slide. So for the CT analysis, I would like to give the word to Mark van der Dorpel, who is our research fellow.
So here you can appreciate the 23mm peri-mount bioprosthesis that was implanted in the past. You can appreciate that there is moderate calcification of the valve leaflets. The dimensions are as follows. There is a area of 355mm squared, a perimeter of 67mm, and an area derived diameter of 21.3mm. The optimal projections are displayed here, an LEO 21 and a Caudal 5, onto the coronary heights. So the left coronary is at 12.4mm, whereas the right is situated at 16.0mm. Then next to the femorals. So you can appreciate that there is quite some calcification, especially in the right femoral artery, also in the abdominal aorta here, and that's also on the left side. In fact, the calcification is so extensive that only the left side was usable for access, whereas the right was totally occluded, as you can see here. So that's why we had to go for shockwave therapy on the left femoral, which was done successfully minutes ago. Then I would like to show you some of the coronary on the sentinel projections. So you can see here that the dimensions are suitable for sentinel placement. So both the brachiocephalic trunk and the left carotid artery are wide enough.
Yeah.
Back to you.
In terms of the evaluation by CT of the failing transcatheter surgical valve, we didn't encounter too many issues in terms of coronaries. We had our sinuses that were wide enough. The height of the coronaries was also plenty, so no issues there. We were concerned about the peripherals, as you mentioned, and we'll get to that in a second. But let's also put education to practice. So I described this simulation, what we're doing with either FEOPS or Materialize. Maybe we can demonstrate a simulation of this particular patient with a failing peri-mount. So can you demonstrate what could happen if we implant either an evolute valve or a sapien valve?
Yeah, absolutely. So here you can see using the new tool, which was provided to us by Materialize, using advanced image segmentation, the 23 millimeter pyramid bioprosthesis. And then if we go on to the next step and then choose device, we can either choose a Sapien or an Evolut valve, and then also select any size. And here you can beautifully appreciate what would happen in an atomic way. So this AI-based tool automatically generates, for example, valve to coronary distances, which is really very insightful and adds a valuable extra tool to the procedural planning.
Yeah, and you can obviously also play around with different depths. So if you now just convert it from Evolut to Sapien, what would happen if we implant a Sapien? Obviously, you see that relative to the coronaries, this is a day and night difference. And that is exactly why we are still considering Sapien valves for our failing surgical prosthesis. As a matter of fact, we are doing a randomized controlled trial in that regard. Can you elaborate a little bit on that, Herrier?
Absolutely. So if we can get back the slides, I can show you the flow chart. So this patient was enrolled in the baseline study. So the baseline study is a randomized controlled trial that focuses on patients with failing surgical valves who are accepted for TAVI. And then, so we just found out that we can have insights on the interaction between the transcatheter valve and a surgical valve if we use a Sapien or if we use a balloon expandable versus self-expanding. But there's only one way to find out clinically, and that's to do a randomized trial. So next slide, please. Again, next slide. So this is the baseline trial in which we seek to randomize a total of 440 patients to either self-expanding with the Evolut platform or balloon expanding with the Sapien or MyVal valve. And what are we looking for? The primary endpoint is at 30 days, which is device success according to VARC-3. And the co-primary endpoint is at 1 year. It's a clinical endpoint, a composite of mortality, stroke, and rehospitalization for heart failure. So this patient was randomized to the Evolut platform. So that's the reason that we selected this valve for this patient. But we would also have obviously felt very much comfortable with using a balloon expandable valve.
Yeah. All right, any questions, Kendra, before we move on with the case?
In your pre-procedure planning, are you able to use any of that in the lab? Because what you've also simulated is the depth of implant.
Yeah. So now, for the time being, we are not using fusion imaging. But there is, we are working on this together with both vendors to get a fusion on fluoroscopy. Obviously, that might even benefit or may benefit a little bit further. That said, I think the visual appreciation that we get from the analysis that Mark just shows us already is reassuring in terms of coronary access. I think there is no issue whatsoever here that we need to protect the coronaries in any way. Even if we would consider an Evolut valve, we would also, so here, as demonstrated here, can we show the simulation by Mark again? So here you see that basically even the supraannular leaflets will not interfere even down the stretch with coronary access if we would, for instance, face another degeneration of this particular valve. But obviously that is not expected for this patient.
Well, let's ask our panel which valve they would choose, just based on what you've seen. Start with you, David.
Yes, well, in this setting, we would definitely be taking the core valve because we think there's enough evidence to support the use of supraannular valves here. But I strongly support Nicolas in doing this randomized trial. And actually, we were very keen to participate, but unfortunately, the UK couldn't make it over the line for some appalling Brexit-related reason or something. Anyway, so I think, we would definitely do that. We think the gradients are going to be higher with the balloon expandable valve, with the intraannular valve. I think the supraannular technology is ideally suited to this. So that would be our choice.
And Giuseppe?
So for me, Sapien, I follow, randomization. And I'll tell you why, because actually by FIOPS, I don't have experience with FIOPS, but PTA on the left-hand side towards the left main seems to use anyway. You need to go for orientation of the core valve. Otherwise, then, you might have any problem in case this is not the case of third intervention and so forth. And actually, I will be surprised with this, valve, surgical valve, if you go with Sabinin, and in case we refracture to see gradients that are above 12 or 13. So actually, for me, it's fine to go with Sabinin.
All right, very good. Well, certainly let's go forward with the case.
Yeah. So Kendra, what we already heard is the appreciation that self-expanding valves would be associated with better hemodynamic valve performance. Obviously, that is based on echocardiographic assessment, and there is a lot to do about the difference, the discrepancy between echocardiographic assessment and invasive evaluation. So we have been working in that field for quite some time, and it seems that with invasive evaluation, there is not much difference between a sapien valve and an evolute valve, and that is exactly why we are doing this randomized controlled study, because we're also monitoring invasive measurements, invasive hemodynamics surrounding these TAV and SAV cases, and we also want to see what correlates best with outcome. Is it the gradient that we measure by echo, or is it the gradient that we measure invasively? So let's bring you to the case where we are now. So we have a right radial access for that accommodates the sentinel. So we have cerebral embolic protection. We do that typically in all our cases, but definitely also in failing surgical prosthesis. And then we have one little needle here punctured through the right femoral skin here, inguinal skin, for pacing purposes if needed. And then we have a 7 French sheath, and that's it. That is our access. So we have no access for a pigtail. We feel that the pigtail doesn't add a lot in these failing TAVR cases. So we only have a 7 French long sheath, 65 millimeter sheath. And we did prepare the iliac trajectory with shockwave. And can we briefly show a couple of those, maybe the last shockwave run? So we delivered 300 pulses throughout the entire iliac trajectory, and then at the end with this balloon we went back and forth to see whether it was easy to navigate with this balloon that has lost its profile, obviously, whether it would be easy to introduce a 14 French sheet. So far we haven't introduced the sheet. What we did do is we did implant the sentinel, and then we also crossed the valve, and so now we are in the valve in the left ventricle with a pigtail catheter. And can we then briefly show the hemodynamics? So you see the pressure measurement from the pigtail in the LV, and then we have this long 7 French sheath in the groin with its tip at the aortic arch. And so this is where we have simultaneous pressure measurements in the LV and in the aorta. So this is an important baseline assessment that we would want to do in the context of treatment of a failing surgical valve. So with that, I think we are ready to proceed with the introduction of the 14 French Centron sheet. So why don't you bring the extra small Safari? So why the extra small Safari? Because it's such a hypertrophic ventricle, small cavity. This is our wire of first choice, and that's going in nicely. So what we do now is, as a unit, we take out the long sheet and the pigtail. Yeah. And so then you can also see the construction, how we do the simultaneous pressure measurements. All right. So we have. Can you briefly show that, Herrier? So the long sheet and then the pigtail catheter. Can we briefly highlight that on the camera? So this is how you can basically, with one catheter and one long sheath, have a accurate transaortic gradient assessment invasively. All right, so let's insert the 14 French centrant. Okay, so again, we prepared the entire trajectory with that shockwave balloon, a 7mm shockwave, and hola, this is very nice. Very pleased. This goes nicely in without any major issues. I do feel the friction of the calcium, but let's take that out, and then through the N-line system, we can try to insert the evolute. All right. So Stefan has prepped the evolute offline. So this one is ready to go. All right. And then Herrier controls the wire. So the patient is wide awake, obviously. That's how we do it. And this is where she does start to feel something. And I also feel a lot of resistance. So let's have a look in the groin there. What are we facing? Oh, there's a little bit to my surprise, so let's see. Oh, yeah, there's a lot of calcium there, huh? Oh, yeah. Yeah, okay. So this might... Oh. Sorry, mevrouw. Okay, so can we walk this out for a while? Okay. Okay, so let's go again. Okay, this is not gonna work. So what we do now is we're gonna walk this out and then bring back the 14 French sheet. Yeah, walk it out. And I need also a stiffer wire. So, yeah, we're gonna opt now for the Emory wire. So let's bring that 14 French sheet. I'm a little bit surprised that the 14 French sheet went in without any issues. Still, without any issues. Okay.
One comment, if I may.
Yeah.
Yes, please.
You're doing really nicely, Nicolas, with this slight unexpected situation. It's one of the real advantages, of having the patient essentially awake, because sometimes with cases where the patient has had anesthesia, that dulls these responses. And actually, so having the patient able to say, actually, that feels quite, tight, quite unpleasant, is a really good way to us to say, okay, we can't push any further, we must do some more modification. And that's actually a really good safety thing. Yeah. So in that sense, I think it's really helpful.
Stefan? Yeah, I totally agree.
I agree with you.
I totally agree.
I also, while he's rewiring, what are your practices in regard to lithotripsy facilitated transfemoral TAVR? Are you aggressive with this? In our practice, it increases our population about 2%. David?
Yeah, I mean, I must say we don't really do much lithotripsy in the femoral and iliacs. We tend to use balloon therapy on its own and only go for lithotripsy if we're really sure that we need to go from a femoral rather than, for example, transcaval or transartillery. So we rather than push a difficult femoral, we personally will be quite likely to move to a percutaneous transartillery at our heart team meeting. Having said that, of course, lots of people have gained lots of experience using lithotripsy and pushing the anatomical arena in which you can access to the heart from the leg. So I think either strategy is perfectly good.
And Giuseppe, how about in your practice?
We use lithotripsy, but after lithotripsy, we used to go with an infuser out 18. Sometimes we go with a balloon to make more effective.
Okay, okay.
And so the lithotripsy, you're saying that you would then dilate like he's doing here, and if that failed, then you would go with an actual angioplasty balloon. Yeah, that's similar to our practice as well. So let's turn it back over to Nicolas. Looks like they've got the wire in place and they're ready to attempt the valve again.
Yeah, exactly. So this is the Inoue wire. This is a bit stiffer, well, quite a bit stiffer than the Safari wire. And well, what also was of notice is that we did some atherectomy with our NVO system because we saw some tissue around the frame of the valve. And let's see if it wants to go. Yes, now it goes. So this is the value of that stiff wire store. So I'm kind of pleased with that. But again,
Well,
this is
wonderful that you were able to
hostile
pass that.
anatomy.
Can you also comment on the actual delivery and where the flush ports and things? We spent some time earlier talking about commissural alignment, and so what are you doing to assure commissural alignment at this point?
Yeah, so we inserted at 3 o'clock with the flush port, but now in an LAO projection, we want to make sure that we are that we also have the commissural alignment, and you want to have this open head on the outside of on the right hand side of the screen, and that is exactly the case. So I think in terms of commissural alignment, we are in good shape. So now we can continue. You see the filters, so we want to make sure that we don't dislodge the filters. And there we go. Here we are. So also what is important, and Rakesh, maybe you can show this. So I'm not forcing the entire NVO sheath in the patient. So basically, as it got stuck in the iliac, that's where I left it, and then I only advanced the delivery. So I didn't introduce the entire system. Okay, so I can protect myself again, and then let's continue with the deployment. So give some magnification here. Okay, we're in good shape. Let's start. So the beginning, we can.
Do you control the orientation cusp overlap or not?
Well, yes. At the end of so upon 70 or 75% of the deployment, you will see that. So basically, this is a coplanar view. You see the 3 posts. Okay. So yeah, we're gonna connect the pressure on the side branch. There you go.
In the meanwhile,
okay, go ahead.
So actually, what is important also for the audience, in case you have to reorient the valve, it's not recommended to keep the valve in place there, because this FX valve and actually the risk with this connection of the two spines.
Okay, so resheet. Yeah. Okay, resheet. Yeah. So first we're gonna resheet this thing. So in principle, you see the 3 dots that are already co-aligned with. Oh, stop. Wait. Yeah, open up. Yeah, open.
So we were a little deep on that first, and I see that he's repositioning.
Yeah.
He was talking about the gold markers on the new FX valve, and they're at 3 millimeters on the frame. And so in a native annulus, that puts you right at the annular plane. So the goal is 1 to 5, but right at 3 is kind of the sweet spot, where they think that that's the place where radial force will optimize for PVL as well as depth of implant. So they nicely repositioned, and it looks like we've deployed fairly quickly.
Okay, so we see, so store this. We have a lot of under expansion of the frame. So now we opt for more aggressive post dilatation already. So we're gonna walk this out, Hervé. And you're gonna see once we post dilate this depth will be perfect. But you see the 3 dots, and 1 dot is underneath each post of the perimount. So this is commissurally aligned, 100%. So that's nice. So we don't even need cusp overlap in this case. Okay, so now we walk this out. It's gonna be a little bit sensitive. Een beetje pijnlijk, mevrouw. Komt goed? Ja. Oké. There you go. En dan ook de dingen loskoppelen. Hè? All right. I'm telling you, this stiffer Inouï wire is a joy to work with in more complex peripheral anatomies. It was really helping us out here as well. And amazing how easy the centron sheet goes in, huh? All right. Okay.
And how are you choosing your balloon, Nicolas?
Yeah, so we don't want to fracture as of yet. So first, this was a Perimount 23, and obviously we did a complete assessment by CT, and the area-derived diameter is 21.3. So that would be my first guideline, if you will, for sizing when I treat a failing or a TAF in a failing surgical prosthesis. So the area-derived diameter, not the minimum, not the maximum, but the area-derived.
Very good.
This one is
Giuseppe,
good.
There are some teams that are saying crack all of them as long as the sinuses are bigger to optimize. Are you cracking all of your surgical valves?
Crack the old surgical valve. That's what I used to do, is to go with a balloon that is 2 millimeter bigger than the inner diameter of the valve, or 1 millimeter bigger of the outer diameter. So in this case, 23 millimeter, 2 balloon, you can do both things. It's the dilatation or cracking of the wing.
Stop pacing.
Yeah, I like this idea of optimizing
And store.
the TAVR valve and just kind of getting it to fully expand. David, what's your practice?
Yes, so similarly, we won't expand every surgical valve.
Met de
because, I mean,
7 French.
inevitably, there are some risks inherent in that. You can have risks of ventricular septal defect, of annular rupture, of embolization of your TAVI valve. So, I mean, it's not a free lunch. We will tend to measure the gradient and possibly look echocardiographically. As a very general rule, we will expect to crack anything that's 21 and smaller. Anything that's bigger than 23, we were most unlikely to break. 23 is the only one where we're a little bit undecided, but actually increasingly frequently we leave them alone simply because of the additional risk, because actually the hemodynamics are pretty good if you put in a supraannular valve.
Yeah, I think we've learned a lot from our experience now globally, and that was really aggressive, crack them all. That's being tempered by some of those risks. So, Nicolas, you're just hooking up to pressure. Can we see that a little bit bigger?
Yeah. So can we? So we're now zeroing first. Obviously, that is what you need to do. So let's re-zero. There you go. So, and then again, we have the tip of the long sheath in the ascending aorta. And then we have the pigtail in the LV. There is no gradient whatsoever. There is nice expansion of our evolute valve. This looks very good. And if you then look, if you appreciate here by cine, let's make a small cine, then you see the 3 dots, and the distance from the dot to the edge of the frame is 3 millimeters. So I think we are the level of 3 to 4 millimeters under that, across that bioprosthesis. So I think this is a very, very nice result. And again, if we go back to the hemodynamics, there's no point in fracturing this, because this is not, as David said, this is not a free lunch. The more aggressive you get, the higher the likelihood that something will happen, higher likelihood of aortic rupture, but also the more you will change this VTC distances and the VT to the valve to sinutubular junction distance. So you don't want to distort this at this particular time. So I think we are quite pleased with the result in terms of hemodynamics. So what we're going to do now is pull the pigtail catheter onder het knopje, and then we're going to make an aortogram. And so we don't have a separate access for our pigtail. So basically, if you're not a believer in filter-based embolic protection, you could even do it with one access, just one single access. Are we ready?
Yep.
Okay. Well, based on the AR index, this should be a perfect result, and this is a perfect result. The AR index was 39. There is no PVL. We have no residual gradient. We see the coronaries popping up there. This is a very nice result. We are at 6:38. Maybe it's an idea, Kendra, to go to your colleagues at Emory. And
yes, they are
if
ready.
it's
I was just
possible.
waiting for your final picture. Yeah, I was just
Yeah.
waiting for your final picture. Excellent result, excellent demonstration of revalving with an evolute. We're going to now go to Emory, where I can see that Adam and Vasilis are ready for us. So Adam, Vasilis, can you hear us?
Go, Adam and Vasilis.
Hey, we can hear you. Can you hear us okay?
Yes, of course.
Yeah.
Tell us about your case.
Fantastic. Asita, you want to
Sure.
introduce everybody and take over?
Yeah, thank you. My name is Isida. I'm here with Adam Vasilis, Guy Payon, our fellow Errol NC, our scrub tech, Steve Matke, with Corey and Eric from anesthesia, and Dr. Gleason and Dr. Ho from the imaging team. And we have a valve-in-valve case to share with everyone today that I think is slightly different than the one that was just shown. So hopefully it'll be a good overview of different ways to do a case. I'll let Dr. NC introduce the patient slides, and then we can discuss.
All right, great. Can we go to the next slide there? All right, good afternoon, everyone. So we're going to present today a 75-year-old male. As Dr. Buku said, we're doing a valve-in-valve TAVR today. This patient had what we believe to be a Paramount 2700 23 millimeter valve that was implanted in 2018 with degeneration causing severe AI. Patient had a cardiac MRI beforehand showing an ejection fraction severely reduced with an EF of 26%, regurgitant fraction of 41%. Other comorbidities listed here, notably does have a pacemaker in place as well as a prior MVR, which is also performed at that time. We can go to the next slide. Next slide there. Here's our prior CT workup. No risk of coronary obstruction. We have plenty high coronaries, and there's kind of a rotational view. All right, we can, and implanted there's a projected 23 valve. You can go to the next slide. Here's those valve parameters that we have. And we, like I said, we believe this is a Paramount 2700 based on their registry, but on fluoroscopy, there is some question. This is a 2800, and that becomes relevant if we're talking about expansion versus fracture when we actually are ballooning the pre-ballooning this valve. We can go to the next slide there. Here's our CT projections, a 111 view and a 21 view. We can go to the next slide. And so our strategy today, we have our large bore access on the right side. We're going to perform a balloon valve expansion versus a fracture. We have a 23 as well as a 24 true balloon available with plan to place a 23 millimeter S3 Ultra Resilia. And I'll turn it back to Dr. Buku for further discussion.
Sure. So as Errol had mentioned, based on his card on his wallet, this was a 2700 Paramount valve. However, as you can see on fluoroscopy, and I don't know if he has a live fluoro showing on the screen, but this looks more like a 28 Paramount or a Magna, and which would be fracturable as opposed to expandable. So, you know, this gentleman is 75. He's an avid biker, very physically active. He degenerated his first valve within 6 years of implant, and you know, we were thinking that if we put a 23 millimeter Resilia now, we can save room for a core valve as his third valve, because I think he is quite likely to need one.
Patrick, do you have any baseline images to show of the AI maybe, or?
Yeah, we can just kind of take a quick look here at what we're dealing with in terms of the baseline AI as we currently see it.
You guys see everything? Just make
We do.
you guys can see both fluoro, hemo,
Yeah, we
and
do.
TEE.
Everything looks
You got
great.
everything up there? Okay.
And you.
Great. It's what my job is, to look good. Okay, so what do you guys think here? What's the truth? What is the truth? You know, the registry in his card says it's a 2700. When you look at it fluoroscopically, it sort of has that old cap gun pattern to suggest maybe it's not. So we were thinking maybe try and do BVF here before we put the valve in with a 24 true balloon. See if it's going to give or not. If it doesn't, then we'll put the valve in and maybe post-dilate and do BVE with a 23 true balloon. At least that's our current thinking.
And were you
David, why don't you
thinking to do
start?
the balloon valve cracking first, partly because he already has severe AR, and partly to preserve the leaflet function of the S3 that you're going to implant?
Correct. And also to know if it is truly crackable or expandable.
Yeah.
And if you thought that it would change your strategy, then, maybe you do it first. If it's not going to change your strategy, you're right. You could just put the valve in and go. But we're just a little confused as to what the valve actually is. So our valve is ready to go. We have a 23 Sapien Resilia ready to go. So maybe we'll see if we can get this thing to crack. Ashita, you'll give that and then give it to me. Yep.
All right.
Adam, talk us
Ready
through
on the
your balloon
pacer?
choice and
Yeah, we have someone on the yeah.
You need the probe back.
A tiny bit so they could see. We have someone on the pace. You guys ready to hold some ventilation? So it's a 23, some version of a Carpentier Edwards that has a true inner diameter of about 21. So a 24 balloon here, one larger than at least the labeled diameter would give us a little bit more pressure to exert. Obviously, if you were doing it post, maybe you wouldn't want to put a 24 in. He does have room in the LVOT and room in the sinuses. So we thought that would be a reasonable way. Now, that's just a true balloon. Some people have gone to Atlas Golds, right, that don't tend to rupture as much, but have a much slower inflate-deflate. So you got to be patient with those. We're not going to push this too hard here. We're going to see.
All right. Ready?
Yep.
Full ventilation. Pacer on at 180.
Oh, can you show us the fluoro?
Yep. We're going.
The fluoro, please.
Switch to me.
Yeah.
Here we go.
Let me
So,
deflate.
so on.
We popped up a
I'll say
bit here.
off
Off
the pacer.
pacer.
Pacer off.
We're just going to reset this balloon a little bit. Can you see fluoro okay?
Yes.
We can now.
Okay. We'll switch to Cine, so it may black out for you on us for just 1 second.
All right, let's try it again. Full ventilation. Pacer on 180. Yeah.
You to me?
Yeah.
Man, I don't know if it's done anything yet. I'm at 12 here. I'm at 14. I'm at 18. I'm not sure it's going to.
Oh, okay.
Did it pop there? I just saw a drop
Pacer
on
off.
I had a drop in pressure on the delivery system. So
The valve.
it looks like it may have.
It looks like that corner there.
Looks like the bottom corner is cracked.
I'll do it for you.
I got you.
We can play the picture again and see if it popped too. Once they get the balloon out, you want to help walk it out
Yeah.
with me? Is it coming okay or no?
No, I think you need a little more negative for a rewrap.
There's plenty.
Okay.
You want to push it back in then,
Uh-huh.
so we can see it on the screen. I'm going to play that picture again for a second, guys. I think about 18, it kind of dropped suddenly on me here.
Very last.
Yeah, right there. Looks like it did it. Okay.
Yes.
Let's see if we can get
Yeah,
this
we
out.
saw a slight movement in the bottom corner. Certainly, if you had a pressure drop, then you've
Big
done
drop.
everything that you want to do.
Yeah. Well, pressure drop and no balloon rupture. That's two good things that go together, right? Like peanut butter and jelly.
Nice, and he's tolerated it perfectly well.
So
AR
the fact that we,
is-
Yeah,
we
we can
have,
take a
I
look.
have not really seen the
I have it.
sort of the catastrophic leaflet damage fire drill that people talk about with the pre. We could talk about the data that would support better expansion post and everything. I get all that. In this case, I just wanted to know if this was going to be crackable or not.
Adam,
I guess if you couldn't crack it, you could argue to. Go ahead.
do you use cerebrovascular protection when you do this or not?
Sorry, had a tough time hearing you. Say it again.
Are you using Sentinel?
Cerebrovascular sentinel. Yeah.
Oh,
Oh,
yeah, we spent a lot of time trying to recanalize an occluded radial. He had a bunch of caths before this valve, so we unfortunately, the plan was to use a Sentinel, but could not ultimately make it work.
we
Otherwise,
normally
yes,
would.
we would.
Yeah, we're a sort of,
My
for
what?
all these cases, we would use a
Okay,
Sentinel.
yeah.
So, I guess if you couldn't fracture it and you could only, you went to high pressure and it wouldn't fracture, maybe you could call an audible if everything was stable and switch valve strategies and go to a supraannular design, right? I think now that it's fractured, I think this concept of, getting a sapien inside and then hopefully he's got one more in him. I mean, he's got plenty of room in the sinuses. And so I think a valve in valve here is doable for him. We sort of look at those things before we make our final
Ready?
decision.
Somebody want to turn or
Mm-hmm. Ready?
You're about 3/4 here.
Okay.
I'm going to go ahead and take all the
Asita,
flex
talk
off
to
here.
us about where
since
you're
Russ really-
planning your implant depth. What are your targets? What are you looking at?
Yes. So with this, the lucent line should be at the bottom of the frame. It's the actual stent frame height is 16, so it's shorter than our
You're plenty far back.
yeah. So we need to go in a little bit here. Line it up to about there.
Patrick, was the AI worse after the fracture?
It was not. No, same.
Okay.
No change. Looks like it's central.
It's always hard to figure out if the leak is central or paravalvular on some of these. There's so much shadowing. So there also was that slight unknown. We're sort of prepared to do PVL closure too if it turns out that it's outside, but it's just so hard to tell. The
Yeah.
presumption would be that big a leak shouldn't be paravalvular this many years out, right?
And it looks like we were able to get, I know that on the baseline we didn't have,
Seems a bit low.
condition, but it looks like it's coming from the leaflets here. Yeah.
Yeah, on CT there was no gap. There was a very tiny gap in the right commissure,
ready?
but no.
yeah.
All right.
You want to pull back just a little bit, Patrick, so we
Yep.
can see the top. Yeah, I think you're okay there. You
Yeah.
can push in a little bit if you want.
We
You
are
guys want to
not-
get ready on the pacer again? Maybe we'll go 180, 200 this time. They're holding ventilation for you.
All right. Pacer on, 180. 200.
All right. Push it in a little
Go for
bit.
it. Yeah. Mm-hmm.
Oh, yeah, I think you can.
I'm holding. Yeah. There you go. Good.
We got a couple of extra in the syringe.
Yeah, I left one in.
Pacer off.
So we were 3 extra, I believe.
breathe.
You left,
I left
one
one
in, so I guess in total we were 2+ here. Valve looks pretty stretched open, right?
Mm-hmm.
I mean, I think if you put a 23 in, a valve with a 21 true inner diameter, those cells on the bottom always look a little crunched, right?
And we don't have any AI right now.
Perfect.
There's a little bit of wire
Pull the wire back a little bit.
leak, but
So now would you further post dilate it? So here's where the pre-post
I have it.
BVE, BVF comes in, right? The proponents of
Well, you want to
post would say that there's better valve expansion if you hit it post. So we could come in with a 23 true here to straighten it all up if you want. Guess we'll put a pigtail in and get a quick gradient though. Let's mag back up and take a look here. Cool. What do you guys think of expansion?
I see that your current wire position's
Giuseppe?
pinning open one of the
A
inputs
leaflet.
here,
Okay,
Giuseppe.
well, we're
Yeah.
about to fix it.
We'll get a pig here in a second. Looks, the bottom cells look pretty wide in terms of their angle.
Yes, I mean, the valve looks very widely expanded. I wouldn't want to post dilate it from here unless there was a particularly good reason to do so.
Right.
We actually ended up with great alignment.
Giuseppe,
of
what ingredient are you
commissures,
going to
TAVR
accept?
commissures with the
Single digits would be great, but
Yeah. So it is. We are using the Resilia, which we have found in our series and in a multi-center series, and then of course the recent publication in JACC with the TVT registry data that the gradients do seem to be proportionately
A little lower,
significantly
yeah.
lower with the Resilia.
Giuseppe,
compared with the
was
Ultra. So whether we can get down to single digits, yeah. Go ahead.
Giuseppe, you were commenting, but I believe you're muted. We couldn't hear you.
Oh, I think I would expect to see a single digit gradient here.
We'll do our best.
And Giuseppe, you were starting to say that you thought
just
that
re-zero
your
there.
initial implant depth was a little bit too low. Are
Little
you
bit
happy
too-
with where it landed?
But actually, it's okay at the end because of the foreshortening. But I used to stay a little bit higher, but it's matter of details, nothing special.
And Adam, can
And
you
it's
share
nice to
your
get it
hemodynamics
at the
with
top
us?
of the posts Yeah. Vlad, could you make sure hemodynamics are up? We're just zeroing our transducers here, and then we're going to get them up for you. We like to get the valve maybe at the top of the post, if not a little bit higher. Maybe 1 or 2 millimeters higher.
Yeah.
Certainly wouldn't have hurt. Given wide sinuses, looks like there's.
Yeah.
I mean, anatomically and fluoroscopically,
Can you see the
it looks
hemodynamic?
extremely good. So I'd be very surprised to see any gradient of note.
Yeah. Oh,
Exactly.
yeah. You guys see that full screen or no?
Yes.
We're seeing a little bit
Nice.
of gradient here. Maybe peak to peak looks like it's about 6, 7. We'll see what the machine calculates the mean to be here, but we're seeing about 7 maybe.
You're getting a mean of 5 by echo.
Yeah.
right?
I'll do a pullback and see.
Yeah, we could also do a pullback, just make sure. Yeah, I think but our machine's calculating 9 for a mean. There's a little delay, of course. We haven't phase shifted anything. And now if you look, we've pulled back here, and now we're seeing still, there's still a little bit of gradient of about 2 to 3 here, peak to peak. So some of it's just our catheters drift. Sometimes our pressure thing drifts a little on the hemos. So I mean, it's still single digits. So any need to post dilate, or do we call it a day?
I think so. Well, we can do
We
it.
have everyone shaking their head no
don't think
here.
you can
Adam, I
work
think
with the
that's a
both
great
sides.
demonstration.
Yeah.
So we only
So
caught
nature.
the end of Nick's case, but it sounds like they did a valve with an evolute and no fracture. Is that right?
Can we roll forward on the
That's
prior
correct.
Yeah.
Yeah. So we're
And so
going to
what
have you
valve
take
was
this
it that
final
the evolute
shot.
went in?
We're going to have you take this final shot, and then we have to wrap up. We're running out of time, unfortunately. But this was an absolutely excellent demonstration of revalving with a Sapien.
Inject.
Hopefully we'll see that there's no residual regurgitation.
Want to get him out of the stomach or no?
Inject.
Yeah. Certainly the AI is taken care of.
Beautiful.
What seems there is that there is a runoff that is a little bit delayed on the left main.
In the left main? I mean, we're not in a left side view, so it's
Probably you can go in
behind us.
LAO just send it.
Um,
I didn't know about the flow before, but I'm not there. So
Prior Lima to LAD bypass.
yeah.
So he has
Yeah,
existing
he's got
native.
he has a
disease that
patent
he's
Lima to
bypassed.
LAD bypass that
Yeah.
might be some of it.
okay, fine.
Kendra, do you think we can get an evolute in there next time? looks like you set up pretty well
If
for
the
that.
patient needs one,
Yes.
yeah, if the patient needs one, I think that you're set up well for it. Let's hope that he never needs it. And on that note, we do have to wrap up. Thank you, Asita, Adam, Vasilis, and team there at Emory. Thank you, David and Giuseppe, for joining this panel, and thank you to the great cases and thank you to the patients for the great cases that they were willing to have us show today. Before we say goodbye to this first day of TIO 2024, there is a breakout session that will follow this, New Horizons in Structural Heart Intervention. And that breakout session will start shortly after an intro.